Thank you, Shugatoda, for having me in this session. Proud privilege to present in AIOC. So my topic for today will be phacoemulsification in corneal comorbidity. So pre-existing corneal pathology may compromise surgical technique, may lead to suboptimal or undesirable results post-operatively, or even after cataract surgery over a period of time, the corneal pathology may progress. So for best possible outcome, we should be able to detect and correctly identify the corneal pathology and initiate appropriate perioperative management. So beginning with Fuchs endothelial dystrophy, it's very important to identify this pathology on slit lamp before surgery. So we get this endothelial dusting kind of an appearance along with these gray areas well delineated. And if we have Fuchs endothelial dystrophy, as a cataract surgeon, our primary decision will be whether we should go along with the cataract surgery only, or we should ideally do a procedure called endothelial keratoplasty triple, that is combining a phacoemulsification with an EK procedure. So when should we think about an EK triple procedure? If the patient complains of symptoms of early morning blurring of vision for around 2 to 3 hours after getting up in the morning, if the central corneal pachymetry is more than 640 microns, or if the specular parameters are of poor quality. However, we must remember that these low specular parameters is the least important among the three of the criteria. And intraoperatively, we should use good quality viscoelastic, particularly dispersive ones, and a soft shell technique would be preferable. We should use BSS as the irrigating fluid, and we should modulate the power to decrease energy dissipation in the anterior chamber with increased dependence on fluidics. The next is dry eyes. We all know it impaired tear film. The impaired tear film compromises visual recovery following surgery and also increases post-operative patient compliance. Cataract surgery is known to induce or increase the severity of pre-existent dry eye, and the management is based on history and slit lamp examination. On the slit lamp, we try to establish the tear meniscus height, whether it is normal or lower, whether the TBUT is short, whether there is significant meibomian gland issues, or there is staining of cornea and conjunctiva, either on the fluorescent stain or on the lissamine green stain. So we have the pictures here. And so in a patient with dry eye, whether symptomatic or symptomatic and with signs, we should go for optimization of ocular surface prior to surgery with preservative-free lubricants, lead therapy if there is meibomian gland issues, and anti-inflammatory, particularly cyclosporin, taken at least a month. It takes at least a month to show effect. And so it should be started prior to surgery quite a long time beforehand and should be continued for a prolonged period. And what is also important, if there is associated systemic disease, it should be properly controlled. I'll come to that later. And IOL power calculation and surgery is an issue because if you don't have a good air-tear interface, the parameters, the images on either an optical or on the keratometry won't be ideal. And we should, of course, continue dry eye therapy after cataract surgery for patients' comfort. If the patient has had a episode of peripheral ulcerative keratitis, disease control for at least 3 to 6 months is important because surgery is known to predispose to postoperative inflammation in a predisposed patient, and we should go for we should use systemic immunosuppressive in these patients before and after surgery because there is a risk of postoperative corneal melt at the site of the incisions. And in intraoperative consideration, the wound should be placed by while avoiding the area of thinning, and scleral incision may trigger relapse. So we should ideally avoid scleral incision and go for clear corneal incision. And also suturing may also trigger relapse, we need to remember. Coming to corneal opacities, optical biometry is usually not possible in these cases, so we have to rely on ultrasonic biometry, and we may need to obtain the keratometry and the axial values from the other eye of the patient, the normal eye, and then take an informed decision after consulting with the patient and explaining to him the post-operative outcome, the post-operative outcome issues, and significantly compromise intraoperative view may be there in patients with corneal opacities. So endoillumination can be a good option if you have the benefit of having one. And the our options is an only cataract surgery and avoiding PK if possible, because we know that corneal grafts are post-operative surgical issues and they take a long time to heal, and they require patients to stay in follow-up for a pretty long, for years over. And otherwise we do a triple procedure if the opacity is in the center and is dense and is known to affect vision. Now there has been a description of corneal opacity gradation with AIOC, and it's available in the literature. I'm not going into the details. If there is a corneal tear, if there is a cataract in a corneal tear with relatively intact anterior capsule, we should do an only tear repair. If the anterior capsule is breached, the lens matter should be washed. The anterior vitrectomy should be done if the anterior hyaloid is breached, and secondary IOL implantation is ideal if the posterior capsule is either disintegrated or the anterior capsule, we cannot achieve a capsular excess. Now, if there is pterygium, salesman, or EBMD, these are treatable causes of irregular astigmatism, which affects the postoperative outcome and also interferes with keratometry. And ideally, if we should do an IOL power calculation after removal of these lesions. So pterygium should be removed if it's in the optical zone, if it's progressive or highly vascular, and if it causes high irregular astigmatism. If there is SND, we can do a superficial keratectomy before doing this keratometry. And in EBMD patients, if the myads are irregular on the keratometry, we can also go for debridement and PTK. Coming to corneal ectasia, what we must know that if it's a severe irregular astigmatism which cannot be helped with glasses, and the patient needs a... Is my time over?
Sir, 1 minute left. Please go ahead.
I'll be over. It will be over. Need for
How
specialized
much
contact.
time have you put, sir, there? Hello.
Yes, sir.
We have 85 minutes, so let him speak on. We will leave the session by 85 minutes.
I have a couple of, I think.
Yeah, go on, Sayan, go on.
So if there is severe irregular astigmatism and there is a need for specialized CL for postoperative visual rehabilitation, we should go for a monofocal IOL, because if we are taking, if we are planning to use this kind of IOLs, then the toric IOL would be a hindrance. However, if the case is stable and there is only moderate astigmatism and is correctable with glass preoperatively, toric IOL can be considered. And intraoperatively, positioning of the incision is important, particularly in case of PMCD. We should be avoiding the thin area, because in PMCD, the thin area is in the periphery, and visibility may be quite compromised in these patients with irregular cornea. And we should avoid the use of OVD. And we should use OVD over cornea to improve clarity. If there is microphthalmos or nanophthalmos, we should rule out amblyopia, consider comorbidities with gonioscopy, AIOC, UBM, B-scan. If there is a shallow AC, we should think about PI or laser iodoplasty. Optical biometry is preferred normally for short eye, and we need a piggyback IOL. UVL effusion is the chief concern in these cases. If there may be a subluxation of colobometris lens, we have to take care of that also. And paraoperatively, we should utilize mannitol orbital massage, vitrectomy, or scleral windows to take care of high positive posterior pressure. Post-keratorefractive surgery, IOL power calculation is a problem, and we should either employ formula or we should employ methods to bypass keratometry. Intraoperative considerations is important in RK, because these incisions may open up, and we may prefer a sclerocorneal tunnel in these cases, and open RK scars may need resuturing. And in ablative surgery, we should take care that we do not disrupt the pre-existing flap, because that may induce epithelial ingrowth. After, if we go for cataract surgery after a PK or an EK, ideally we should already have done the cataract surgery along with the corneal procedure. Endothelial protection is of paramount importance. Prevention is better than cure, so avoiding the need for cataract removal with a grafted endothelium in place and doing a triple procedure at the time of corneal transplantation, even if there is minimal cataract.